We will continue the prostate cancer part 17. We have general concepts here. Biochemical recurrence increase the risk of developing distant metastasis and the risk of the dying from the prostate cancer. On average, metastasis become detectable on the conventional imaging 8 years after biochemical recurrence. So 8 years after biochemical recurrence, the cancer metastasis can be detectable on conventional imaging. The risk of the recurrence, high pre-treatment PSA level, especially PSA more than or equal 10 nanogram per ml, or high-grade tumor that especially Gleason score more than 7, and high T state, especially T3 or higher. Positive surgical margins, if prostatectomy was done. Positive regional lymph nodes. Smoking, all this considered as risk of recurrence. High pretreatment PSA, that's more than or equal 10, or high-grade tumor, specifically Gleason score more than 7, or high T state, especially T3 or higher. Positive surgical margins if prostatectomy was done, positive regional lymph nodes, and smoking. PSA doubling time, that's a PSA ADT, is known as PSA doubling time, can be used to assess prognosis in men with recurrent or advanced prostate cancer. Is known as PSA doubling time. PSA doubling time is the number of months it takes for PSA to double. So number of months it takes for PSA to double, this is known as PSA doubling time. It's used for prognosis of prostate cancer. PSA doubling time calculation require more than or equal 3 PSA value measured more than or equal 1 month apart. A short PSA doubling time indicates worse prognosis. Already we speak about the PSA doubling time previously. So we need 3 times to measure the PSA doubling time, as I mentioned. For calculation, we require more than 3 PSA value, measure more than 1 or equal 1 month. After recurrence, the PSA doubling time is more than 15 months is associated with low risk of death from prostate cancer over 10 years. Therefore, surveillance is a reasonable option in men with recurrent prostate cancer when the PSA doubling time is more than 15 months and life expectancy less than 10 years. After recurrence, PSA doubling time less than 3 months is associated with high risk of death from the prostate cancer. Therefore, men with the PSA doubling time less than 3 months should probably be treated aggressively, identifying the location of recurrence. We have several criteria help to predict whether the biochemical recurrence is likely to be local or systemic. No single criteria is best, and combination of the criteria should be probably used to help predict the location of recurrence. This is a local recurrence more likely, and this is systemic recurrence more likely. If the recurrence is more than 1 year after radical prostatectomy, or recurrence more than 1.5 years after radiation, this is known as local recurrence. If the recurrence is less than or equal 1 year after radical prostatectomy, or recurrence is less than or equal 1.5 years after radiation, this is considered as systemic recurrence more likely. If post-treatment that the PSA doubling time is more than 12 months, this is considered local recurrence. If the PSA doubling time post-treatment less than 6 months, this is systemic recurrence. More likely is positive surgical margin after radical prostatectomy, local recurrence more likely. If both a negative surgical margin, that is systemic recurrence. No seminal vesicle invasion, the patient have seminal vesicle invasions, no nodal metastasis, and the patient have nodal metastasis, systemic recurrence, and this is a local recurrence. Imaging tests to determine the location of recurrence. The standard imaging evaluation at the time of the recurrence include the bone scan and or abdominopelvic cross-sectional imaging CT or MRI. However, these tests are rarely positive in men with low PSA. Men receiving androgen deprivation test for therapy for castration-resistant prostate cancer perform PONI scan, pelvic imaging, chest imaging when CRBC is initially diagnosed because the risk of the positive PONI scan is 10%, even when the PSA is low or PSA doubling time is long. Men not receiving ADT, CT scan, and bone scan are positive in only 1% men with recurrence when PSA less than 10 and PSA doubling time more than 6 to 9 months. With a PSA doubling time less than 6 to 9 months, regardless of the PSA, bone scan is positive in at least 10% of the men. That the men with the recurrence and not on ADT should probably undergo a metastatic evaluation when the PSA doubling time is less than 12 months, even if the PSA is low. PONI scan and CT scan should also probably be done for PSA more than 10. PET and CT scan appear to be more sensitive than PONI scan and CT scan for detecting the location of recurrence. Some guidelines state that the clinician should consider the PET scan only after bone scan and or abdominal pelvic CT or MRI show no metastasis. The EUA 2021 guideline recommend performing PSMA, that's a PSMA PET CT for initial imaging of men with biochemical recurrence who are candidate for curative salvage treatment. If PSMA is not available and PSA is more than 1, then the choline and flucloxamines were mentioned as an alternative. If the PSA less than 1, the PSMA is more sensitive at detecting cancer than other type of PET scan. Biopsy of the prostate, fossa prostate biopsy to be diagnosed recurrence is performed only when the patient is candidate for curative salvage therapy. After radiation, prostate cancer dies slowly after radiation. Thus, biopsy is often avoided within 18 months of radiation. Post-radiation biopsies are difficult to interrupt because the tissue might look like the cancer, but it might be biologically inactive. Men who are considering salvage chemotherapy after failing radiations should undergo seminal vesicles biopsy in addition to the prostate biopsy because the cancer in the seminal vesicles occur in up to 42% of the men who recur after radiations. After radical prostatectomy, biopsy of prostatic fossa is usually unnecessary after radical prostatectomy, even when the salvage radiation is planned because the biopsy result do not predict the outcome of salvage therapy. Transrectal biopsy of the prostatic fossa revealed the prostate cancer in up to 50% of the men with biochemical recurrence. So this is the transrectal biopsy reveals the prostate cancer in up to 50% of the patient with biochemical recurrence. A positive biopsy is more likely when the local recurrence is palpable, visible on imaging and or with PSA more than 2. After chemotherapy, local recurrence or persistence after chemotherapy tend to occur at the prostate apex. Therefore, prostate biopsy after chemotherapy should include throughout sampling of the apex. Post-chemotherapy recurrence. Recurrence is present when one of the following criteria are found. Rising PSA. There is no universally accepted definition of biochemical recurrence after chemotherapy. However, the serum PSA should decline to low level after chemotherapy and should not rise on successive occasions. After radiation, prostate cancer dies slowly after radiation, thus biopsy is often avoided within 18 months of radiation. Both radiation biopsy are difficult to interpret because the tissue might look like cancer, but it might be biologically inactive. Men who are considering salvage chemotherapy after failing radiation should undergo seminal vesicle biopsy in addition to prostate biopsy because the cancer in the seminal vesicles occur in up to 42% of the men who recur after radiations. After radical prostatectomy, biopsy of the prostatic fossa is usually unnecessary after radical prostatectomy, even when the salvage radiation is planned, because the biopsy results do not predict the outcome of salvage therapy. Transrectal biopsy of the prostatic fossa revealed prostate cancer in up to 50% of the men with biochemical recurrence. A positive biopsy is more likely when the local recurrence is palpable, visible in imaging, and or PSA more than 2. After chemotherapy, local recurrence or persistence after chemotherapy tend to occur as the prostate apex. Therefore, prostate biopsy after chemotherapy should include throughout sampling of the apex. So this is the post BSA recurrence. We speak about it in details. Again, post BSA, the post chemotherapy recurrence. Recurrence is present when any of the following criteria present, using in BSA, positive prostate biopsy, a distant metastasis. This is very important. There is no universally accepted definition for biochemical recurrence after chemotherapy. However, serum BSA should decline to low level after chemotherapy and should not raise on successive occasion. Both positive prostate biopsy after chemotherapy local recurrence, a distance metastasis detected systemic recurrence. Before administering curative salvage therapy for chemotherapy failure, local recurrence must be confirmed by prostate biopsy. Recurrence or persistence after chemotherapy tend to occur at the prostate apex. Curative salvage therapy may be offered when the prostate biopsy shows cancer and cancer is localized. In this setting, treatment options include radical prostatectomy, radiation, brachytherapy, chemotherapy, androgen deprivation therapy, and surveillance. Salvage chemotherapy. Repeat chemotherapy. The ideal candidate for this, it has clinical stage T1 to T2 in 0M0, lesion score less than 7 or equal 7, PSA less than 4, long PSA doubling time, and life expectancy more than 10 years. This is for salvage chemotherapy. Salvage radiation or salvage brachytherapy data are sparse. BEAT or CT scan appear to be more sensitive than PON scan, and CT scan for detecting the location of recurrence. Some guidelines state that the clinician should consider PET scan only after PON scan and or abdominopelvic CT MRI show no metastasis. The AUA 2021 guidelines recommend performing BISMA PET CT for initial imaging of men with biochemical recurrence who are candidates for curative salvage treatments. If the BISMA is not available and PSA more than 1, the Schollins and fluoxetine were mentioned as alternative. PSA less than 1, PSA-MA is more sensitive at detecting cancer than other type of PET scan. Biopsy of the prostate fossa, prostate biopsy to diagnose recurrence is performed only when the patient is candidate for curative salvage therapy. After radiation, prostate cancer slowly dies after radiation. Thus, biopsy is often avoided within the 18 months of radiation. And post-radiation biopsy are difficult to interrupt because the tissue may look like cancer, but it might be biologically inactive. Men who are considering salvage chemotherapy after failing radiation should undergo seminal vesicles biopsy in addition to the prostate biopsy, because cancer in the seminal vesicles occur in up to 42% of the men who recur after radiation. So up to 42% of the men's cancer in seminal vesicles occur in those. So patients who have chemotherapy after failing radiation should undergo seminal vesicle biopsy. After radical prostatectomy, biopsy of prosthetic fossa is usually unnecessary after radical prostatectomy, even when the salvage radiation is planned because the biopsy results do not predict the outcome of salvage therapy. Transrectal biopsy of the prostate cancer revealed prostate cancer in up to 50% of the men with biochemical recurrence. A positive biopsy is more likely when the local recurrence is palpable, visible on imaging, and or with PSA more than 2. After chemotherapy, local recurrence or persistence after chemotherapy tend to occur at the prostate apex. Therefore, prostate biopsy after chemotherapy should include throughout sampling of the apex. This is the end of the part 17. We will meet again in another session. Bye bye.